Hello, thank you for watching this presentation on applying the change laboratory approach to healthcare improvement studies. I'm going to start by explaining the context in which I'm conducting my research, and that is within two fields of healthcare. First of all, palliative medicine or care, which is about improving the quality of life of people facing life-threatening illness and the challenges associated with that in a holistic way. And also the field of psychiatry within the broader context of mental health care, which is concerned with the diagnosis, treatment and prevention of mental health conditions. In the UK, both of these areas of practice are similar in the way that services are organised. There are tiered models of care whereby patients may see somebody from a so-called generalist service, for example, a general practitioner, community nursing, or within an acute hospital, the emergency department or acute medical unit staff. Or they may see somebody from a specialist service, someone with specialist training in either palliative care or psychiatry or mental health care. Or those specialists may be in conversation advising the generalist services, but not seeing the patient directly. And therefore, I hope you can see that healthcare in these fields of practice is necessarily and critically dependent on relationships and interpersonal interactions. This means that collective generation and transmission of meaning within the whole system is dependent on people. And we've come to the research using the perspective of Crotty and others that all knowledge and therefore meaningful reality is contingent on human practices constructed in and out of interaction between human beings and developed in essentially a social context. To give you an overview of the entire study, what you can see on the left-hand side of this slide is the preliminary work we did prior to conducting the change laboratory. We conducted a meta-narrative review and used ego networks as a framework for talking to people about who was involved in care. This then provided us with mirror data to feed into our change laboratory, which I'm going to come on to talk to in more detail. And the overall study is designed to help develop a multi-voice concept for success and improvement in these fields of practice, drawing on our findings to identify where there is potential for further improvement through triggers for learning and change. So you might ask, what is the problem? The problem, I would argue, is that there is inadequate attention to people in system design in our current service organisation. Excellent care in these fields of practice is not just technically safe, but also gives people the confidence to feel safe. And patients experience multiple transitions, boundaries and interfaces between care locations and providers. Negotiating care from a professional perspective needs to be sensitive to patients' priorities. However, this brings them into tensions with structural safety standards, whilst failure to consider those priorities can also result in avoidable harms. We commonly see that education and service delivery plans lack recognition of the complexity of how to enact shared responsibilities in practice. And this means we need to know about the hidden work mediated through collaborative relationships. How is this work valued? What does good look like? And how can we get there? In other words, if you think about if someone you cared about experiences serious mental or physical illness, what would worst versus ideal care look like? Who would be involved? How, when, where, what doing? And how would you describe safety or risk? So why come to Change Laboratory? As I've said, we wanted to bring the hidden work of people into the open and to put it in health improvement language to focus on the human factors issues or otherwise people within the system, recognising when people address gaps in systemic approaches to system design. I included in the subtitle of this presentation the question of purity or pragmatism. Our change laboratory method had a healthy dose of pragmatism included, some out with our control, so we had to move the change laboratory sessions online because of the pandemic, but some in the design, in that we knew we weren't starting from a particular point of acute crisis or working within organisational boundaries, because we recruited people with exemplar roles and experience to take part in an expansive learning cycle from all the different aspects of service in the specialist generalist advisory model and patients and carers. And we worked to level of abstraction from immediate personal practices and experience to consider big picture issues. So our research questions were, can a change laboratory workshop create a multi-voice vision for how the system can be improved and what success would look like? And we wanted to see if we could generate concrete suggestions for change. We also asked, could the Change Laboratory workshop create a scaffolding framework for future socioculturally mediated improvement initiatives? And would this allow us to create a situation where people could be self-assessing in the need for service change? And what questions should be asked within that and by whom? So what did we do? In preparation for the Change Laboratory, as I've suggested already, we co-designed our research with a public engagement group, and we did conduct a meta-narrative literature review, but this confirmed, unfortunately, simply the absence of narratives synthesising the practices within these healthcare fields with common safety, risk and improvement approaches. We then went on to collect ethnographic data from 148 people, including over 100 interviews and more than 32 days of observation with all the different teams as shown on this slide. We conducted some initial analysis of this ethnographic data, drawing on qualitative methods, including narrative approaches and looking at egocentric networks in order to identify active ingredients that must be attended to. And so we came to the Change Laboratory, and we have 19 participants plus myself and another research facilitator, and we've been working around the expansive learning cycle, achieving the items on the beginning of the cycle, particularly thinking about how did we get where we are, what are the challenges, and what are the ideas for change, and beginning to talk about what a new model might look like. We've tried to have conversations about possibilities and implementation of the new model, but this has proved more challenging, not because our participants can't see what solutions would be, but because they see too big a gap to bridge between where we are and what they would like to see in place to solve these issues. And in case anybody's interested, in terms of stimulus for guiding the conversation and discussion during each session of the Change Laboratory, we've been drawing on creative approaches to problem solving from health improvement work, such as those illustrated here. So what has happened? We've been audio recording the sessions for transcription alongside keeping researcher field notes, reflexive notes and task artifacts to feed forward from session to session. And we are currently midway in our preliminary analysis of all of this. And so we started by sharing this diagram with our participants to discuss what is happening in the healthcare system. And you can see here highlighted in red and green the things that they felt were most important for further discussion, in particularly highlighting the fact that informal or family carers often had a very ambiguous role within the system. We asked, how do processes work and how do processes fail? And we talked about tensions. I am going to share more about these in a moment, but I'll just highlight the first one of these, which identified particularly the long chains of activity and the absence but need for overarching quality checks, particularly when someone was being admitted to or discharged from either a particular care location or a service. As you can see here on this slide, people identified lots of things that created good within the system, and a quick glance over these shows that these are all very much people dependent, relationally mediated, human factors issues. We also identified things that were problematic, the stuff in inverted commas that holds everything together, and both actual isolation and perceptions of isolation, again for both carers, patients, and also different healthcare professionals. We also identified areas that were potential queries or questions, such as how creative could people be in individualising care whilst maintaining a balance of equity? And also, if people were to work relationally together, what was the role of forgiveness should people find that the outcomes hoped for were not realised? So to talk more about the tensions, a recurring question in our change laboratory sessions was, what does the system push people to do? And healthcare professionals talked about this system concept, good practice, in tension with what they thought was right in particular situations, and how they felt they were often asked to make compromises to avoid things going wrong, and felt uncertain about knowing what they could do, what they had permission to enact. They also talked about the issue of responding to crises versus being able to do longer term work. And to look at these tensions in a little more detail, often what people felt was that it was only when an acute crisis occurred in someone's care that they were empowered or resourced to act. There was a lot of discussion from all participants about information being transmitted successfully or otherwise, because it wasn't always clear whether it was received, rather than true communication using real-time dialogue. There was questions raised about whether emphasis was on doing things or simply recording things, and as I've already alluded to, a concern that sometimes there was a focus on not letting things go wrong rather than doing things well. People raised issues around the tensions between hierarchies being based on roles and grades, rather than the recognition of experience or expertise or the valuing of multiple perspectives, particularly within institutional settings for carers and patients. And very quickly, the group, although they came from all those different backgrounds of palliative care, mental health, acute medicine, general practice, community, nursing and allied health professionals, patients and carers, became cohesive and considered themselves as us, and saw themselves in opposition to the system, in inverted commas, and talked about this as a tension, with little recognition of the fact that, of course, it was, if not them themselves, people who do create the system. There was also an issue with different parts of the system wanting to bring every skill of the different members of a multidisciplinary team into their own locality, which is clearly in tension with the enormity and diversity of combinations of needs for patients in these two healthcare groups. So to bring that to life with an illustration, a carer commented, observing first about the situation for professionals. Working in an organisation offers a different challenge from being on the outside, managing hierarchies, keeping on the right side of those in power. On the other hand, carers are deeply affected by what happens to the person they care for, and in some ways are freer to ask for more, but often don't know how the system works. And a professional commented, "It's interesting that everyone is struggling. Really useful to know that they want to help, but we need to work with the team rather than blaming the team. So if I have concerns that so-and-so team haven't done certain things, I should pick up a phone and follow up, try and build relationship as well as respect each other's input more." So we went back to our diagram and what was happening in the middle of this, and began to focus on the concept of meaningful exchange as a means of expansive learning to develop safety through relationally mediated outcomes. And you can see here that we discussed the importance of genuine sharing, whether that was dialogue, learning, or relationally mediated outcomes through the transparent discussion and sharing of risks to reach agreement, and agreement too on division of labour, and the need for people to be trusted to make collective, thoughtful and personalised choices, developing creative solutions when needed. The big concern within this model was that the system currently has undue emphasis on artefacts, and that these are used to create a false sense of control, and documents cannot hold everything together. So to try and summarise what we found that the shift needed was, instead of trying to construct systems that don't rely on people knowing each other, something that has been common in UK healthcare to try and make things more equitable, Our energies should be focused on creating systems that facilitate relational working through equitable opportunities for knowing and multiple dimensions of proximity. And I will come on to explain that in a little more detail. This meant we had a new question. What will facilitate social interaction to circumvent divisive differences in patterns, structures, language, tacit understanding and practice goals? Our work has established that equity is not created through structural standardisation, but professionals need permission to work relationally so that they can apply the knowledge that there is no predetermined right means to realise the end in the particular. This requires genuine and meaningful organisational commitment to human well-being in the broadest sense, and the need for equality of access to relational working and care with lower thresholds for triggering relational work. In order to do this, we need collective values, goals and resource so that people have space to invent the intervention through deliberate, thoughtful choices and practical wisdom moving between the particular and the general. And so we developed the concept of collective social safety to describe the importance of professionals, patients and carers feeling safe with each other in a common purpose. And this goes beyond the physical or psychological safety of the individual. It is collective in that it is constructed between people, founded on trust and negotiation of shared understanding and experience, genuine real-time dialogue using shared language and meanings, and flexibility and nuance in the face of changing circumstances or needs. We're using the ideas of relational glue to describe that stuff, that support that needs to be constructed between people to hold or to stick everything together, and relational reach to describe the bridging work people need to do to link across the different parts of the system or services. And I said I would come back to explain dimensions of proximity. We know from evidence in all sorts of scenarios that geographical and physical proximity can be extremely helpful for people working together. But what we found in our discussions was that these other forms of proximity, moral, temporal, linguistic, psychological and social, were just, if not more important, for people to feel close to wider connections, be able to use preferably easy modes and mechanisms, communicate, to develop shared goals and value-based practice, and to see time as a collective resource rather than different people or different teams or services protecting their own time. To illustrate this again with a quote, this is from a psychiatrist who was describing the care of a patient who also needed palliative care for a serious physical illness. And he says, it was by being a bit unconventional that they got a really good outcome for the patient, as good a death as was possible, reflecting how mental health services can be concrete in how they work. But in this situation, we're really flexible, working outside the box in an unusual situation, thinking about, rather than thinking, well, this patient doesn't meet our criteria, thinking about meaning, how can we actually help this patient on an individual basis? And so our work is creating a narrative because stories matter for making work better. We want to move from the left to the right-hand side of this slide. And in order to do so, we need to consider all that stuff in the middle to think better about the making of the relational in our work. We've posed some questions to clinicians, managers, policymakers as a result of our work, and these include what would happen if we didn't refer to choices as risks? When did you, if you're in one of those roles, last take something away to make space from change rather than adding additional layers of work? Where you work, can clinical staff have real-time dialogue across settings? Is time invested to get things right first time? And if not, are you actually expending more time because of the untoward consequences that arise? And what is being done to address realistic whole system costings, whether those are financial or otherwise? My reflections on using the Change Laboratory, it has been really helpful. They've been very productive discussions, and we are part way to developing a shared mental model of good for practice or policy. This is still in progress, and we are drawing on an open ecosystems approach as a metaphor for this. But our participants did find it a challenge to contribute in between sessions, and also to be able to pinpoint moments of change in our historical change matrix, possibly because the continual evolutionary micro changes they experienced made that difficult for them to see set moments of change. However, the method was generally feasible and acceptable. And I also think that this idea of them and us in the system, us and them, and the attributing to the system of sort of the qualities of a sentient being requires further exploration. So what next? We have one more session to go, and there is much rich data for further analysis. I feel like I'm sifting for gold, but I'm also conscious of my position as the researcher, acting as a conduit and being entrusted with things that, as my participants have said, we cannot say, they cannot be said, but they've been said in this context. And I need to think carefully about how I do justice to that in sharing the work. Thank you very much for listening to this. Very happy to receive questions, comments or advice on where we go with this. Do get in touch using one of the mechanisms shown on this slide.